Good afternoon. Thank you for joining us for this year's Pellegrino Symposium. I'm glad you're with us. My name is Miles Sheehan, and I'm the director of the Pellegrino Center.for.Clinical.Bioethics, and I'm excited about our presentation today. We're going to begin with Dr. Nicole Piemonte from Creighton University, where she serves as a clinical associate professor of medical humanities, as well as the associate dean of faculty leadership. Dr. Piemonte received her PhD in medical humanities from the University of Texas Medical Branch, where she studied continental philosophy, medical ethics, literature and medicine, and medical pedagogy. Her current teaching and research focus on incorporating the humanities into medical education in order to cultivate future physicians who are attuned to suffering, mortality, vulnerability, and social justice. Her first book, Afflicted: How Vulnerability Can Heal Medical Education and Practice, was published in January 2018 with the MIT Press, and her second book, Death and Dying, again from MIT, was published in September of 2021. Dr. Piemonte will be followed by Franziska Frankel, who is one of our graduating seniors at the medical school. She'll be Dr. Frankel in about 2 weeks, and she'll be introduced by Dr. Claudia Sotomayor. Ms. Finkel will be presenting her ethics research, which she has done with our Pellegrino Center faculty, Dr. Sotomayor and Dr. Chris Spivak. To return to Dr. Piemonte, I got acquainted with her by reading her 2018 book, Afflicted, last fall. And I had gotten interested in the concept of vulnerability. And I was thinking about how that concept did and didn't apply to older persons. My specialty in medicine when I was practicing was geriatrics. And so I was speaking about this with Dr. Bill Sullivan, who's at the Kennedy Institute of Ethics, as well as the Pellegrino Center. He said, you got to read this book. You got to read this book, Afflicted. And so I got it and I read it, and I was really captivated on multiple levels. First, it deals with medical education. And so I've been doing that almost all my professional life. So that was good. Second, she used continental philosophy in the works of Heidegger and Levinas in ways that were compelling and understandable. Frankly, I usually find my head hurts when I read continental philosophy, and I was impressed by Dr. Piemonte's ability to explain, synthesize, and use difficult material to enlighten and explain, rather than sometimes I've found other people use it to baffle. Third, and most important, Dr. Piemonte's book, Afflicted, it really made me deeply reflective about my own experience as a medical student, resident, and then practicing physician and medical educator. I can remember in 1980 as a 24-year-old on my medicine rotation at Dartmouth Medical School, when a woman came in who I had cared for a few weeks before. She had acute leukemia, and she'd had a rapid relapse after chemotherapy. And the attending physician said, well, we don't have anything to offer. She's going to die. Miles, you're a nice guy. Why don't you go in and tell her that? I mean, at 24, I knew that was weird, that I was the most junior person there. And because I'm a nice guy, I'm supposed to go and tell somebody who dies. She made me think again about the suffering of patients, the ways in which physicians, nurses, all the members of the care team can also become involved in their own suffering while they're trying to provide good care for folks, but also the peculiar ways in which we don't help our students or doctors in training to engage in the dynamics of what they experience. I also remember when I was doing, and this was not at Dartmouth, a fairly large grant in working on palliative care in the Catholic tradition, and I was presenting this at Grand Rounds, and one of the professors said, well, we don't really need this because we do such an excellent job. And I said, well, let's look at it this way. I've never seen any of you in the room with a resident or a medical student when they have to give bad news. And I think that's because you're afraid of it. So I think you need this more than our students. That went over well, as Holden Caulfield would say. But with that in mind, Dr. Piemonte's presentation for us today is more than soft skills: compassion and vulnerability in medical education. Now, for all those who I'm grateful are listening, I want to encourage you to share questions through the Q&A function on Zoom. And we're going to be taking as many questions as possible and hope for a great discussion. So with that, Dr. Piemonte, take it away.
Thank you, Father Shannon. Thank you for that. Might be the most generous introduction I've ever received. So I want to thank you for that. Um, I really appreciate it, and I'm so honored to be here. Dr. Pellegrino is absolutely a hero of mine, and to be able to speak at this event is truly an honor. And I just want to extend my gratitude for getting to be here today with all of you. So if you bear with me for one moment, I am going to share my screen. And we will get started if that looks okay. Does that look okay? Okay, wonderful. Um, so again, thank you so much for letting me talk about some of my most favorite things to talk about when I think about medicine and medical education. I've been teaching medical students now for about 12 or 13 years, and it's really been a passion of mine. And I know some of you on the call will also be, that you also train and teach other healthcare professionals. So while I might share my experience from teaching medical students, I think that what we will be talking about today is applicable to anybody who is in healthcare. I like to start off with this quote that has really informed so much of my teaching. So many of you on the call are at Jesuit universities, teaching at Jesuit schools. I am too at Creighton, and I've been really inspired by so many of the Jesuit scholars. And this quote has really stuck with me for the way that I see healthcare education, and I share it with my students all of the time. I really believe it at my core. Students in the course of their formation must let the gritty reality of this world into their lives so they can learn to feel it, think about it critically, respond to its suffering, and engage it constructively. Now, as far as I know, this wasn't written about medical or healthcare education, but this is precisely it. Medicine is that microcosm of being alive. It is the gritty reality. There's birth and death and joy and suffering and pain and loneliness. And I think that we need to be equipping our future healers to be able to deal with this gritty reality. I think the issue is that we so often fail to acknowledge the suffering that is in medicine. I think we're only beginning to really talk about the existential or psychic or spiritual suffering of patients. And boy, do we not talk about it among clinicians and trainees. I think that this idea of languishing as a form of suffering is important to acknowledge. So this was a New York Times article that came out at the end of 2021 saying that really the most indicative term that we need to be talking about is languishing. And we're starting to see this too in the healthcare education literature and the medicine literature around burnout. We're starting to talk about languishing instead of burnout. So what do we mean by languishing? So the author of this article says it's this neglected middle child of mental health, that void between depression and flourishing. So just not having a sense of well-being. So it might not be that, oh, I'm clinically depressed, but there is this kind of malaise or languishing that so many people are sharing in the healthcare space. The author goes on to say that part of the danger of languishing is you might not notice it, right? You don't catch yourself in languishing, isolating, being in solitude. What's important here and what really captured me about this article is that he says, when you can't see your own suffering, and remember, we're bad at talking about suffering in medicine, you don't seek help, or you don't even do much to help yourself when you can't see it. And I think we have a problem here about seeing our own suffering. This is Martha Nussbaum. I love this picture of her in the New Yorker. She's a famous Aristotelian philosopher. Many of you probably know who she is. I guess as famous as being like a nerdy philosopher, you could be famous, but I really admire the work that Martha Nussbaum does. And it's the recognition of suffering that we're so bad at that she points to. And she really draws the connection between suffering and compassion. So in her book, Cultivating Humanity, she says, compassion requires a sense of my own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me at any minute, that this suffering patient could be me at any moment. She says, "This I will be unlikely to do if I'm convinced that I'm above the ordinary lot and no ill can befall me." I worry about this sometimes because there are times, a lot of times, where the medical students that I'm teaching, they see themselves as the professional and the patient, as the person who is suffering, and that there is a real difference between these two humans in the same space. And Martha Nussbaum says, if you can't imagine your own suffering, you cannot show this patient compassion. So if we take a minute and look at the etymological root of compassion, you see that it's a noun from the Latin, and it's made up of two words. So we've got passion, which means the suffering of pain. So this is why we see things like the Passion of the Christ. It's that idea of suffering or enduring pain. And com is in combination or union together. So the literal translation of compassion is the suffering of pain together. So this isn't feeling bad for someone. This isn't pity. This might not even be sympathy or empathy, but it's the idea of enduring or suffering pain alongside someone, allowing yourself to feel what it might be like to be that person in front of you. So it requires humility, that I too have the capacity for suffering, and vulnerability. That is scary. We don't really like to think about the fact that we too are going to suffer and die. This is why I think compassion is not really a skill that I can teach medical students, because this is a way of being. This is an ability to look at our own fragility, the capriciousness of life, that we too can suffer and die, and that's hard to look at. So in a lot of ways, compassion isn't just being nice. It actually feels risky. It feels really difficult. Arthur Frank is a medical sociologist. He wrote an amazing book, At the Will of the Body. At 39, he had a heart attack, and the next year he had a cancer diagnosis. And he writes about his own illness experience. And what he noticed was this point that he says, it's hard to hear patients' voices because a patient expresses suffering. And he says it reminds clinicians of the conditions of embodiment that most of us would rather forget our own vulnerability to. We would rather not think about the fact that we are finite and mortal, and we can suffer, and our lives can tragically change at any moment. This is why I think we see this idea of professional distance. I see this all the time with my own trainees, is this idea of I have to remain objective, or I have to keep a clinical distance away from my patient so that I'm not skewed by my own emotionality. And sure, while it's important to have equanimitas or keep your emotions in check, this perceived need for detachment to protect oneself from feeling too much, I think this is really a human reaction to suffering, and that desire to compartmentalize it or to scientize it or medicalize it so that it becomes containable and controllable and isn't so scary. The ironic thing is that this temptation to protect ourselves from feeling too much, it can have the total opposite effect of helping us feel better. The result of not connecting to patients is languishing. It is burnout, going through the motions. Burnout, and we'll talk about this later, is not the same thing as compassion fatigue, of feeling too much. Burnout is these kind of factory line like experiences where you're seeing patients 15 minutes at a time connecting to no one. That's where burnout comes from, feeling nothing at all. It's not about feeling too much. I also think that when we maintain professional distance, it prevents something called post-traumatic growth. Some of you might be familiar with this. Most of us, all of us, are familiar with post-traumatic stress, but post-traumatic growth is this fascinating concept that psychologists are talking about, that it's a positive psychological change that can happen after we struggle with really highly challenging life circumstances. So when we suffer, we can either protect ourselves, turn inward, isolate, or there is potential to grow and be changed by this. And this, think about your own life, the moments of suffering that have changed you and made you grow in exponential ways, or other people in your life who we kind of intrinsically know this. You go through hard things and it changes you if we allow it to. If we allow it to. not by hiding from it or pretending it's not as terrible as it is. We don't grow that way. We grow when we're willing to face hard things. So post-traumatic growth can look like an easier ability to connect to and relate to others. You might gain an appreciation for life that you didn't have before. You're more emotionally strong or resilient, enhanced spirituality. Maybe I can share a story from my own life that will give you a better sense of what I'm talking about here. So when I was 19, my mom was diagnosed with late-stage ovarian cancer, and I took care of her for 2.5 years before she died. And absolutely, the experience of her dying was traumatic for me, for sure. And I think I probably did have PTSD. It was horrifying. And on the outside, it might have looked like I was experiencing post-traumatic growth. I studied death and dying. I went on and got a PhD. I've been committing my life to helping medical students better deal with existential suffering. But when I look at it, I was running from myself. I didn't feel anything at all. I was absolutely numb. I just kept going to school and trying to achieve so that I didn't have to feel anything. And it wasn't until a while later that I allowed myself, it all caught up to me, and I allowed myself to grieve. And a few years after that, my dad was diagnosed with terminal gastric cancer. And it was terrible, but I tried to allow myself to feel those things. And I do think it has changed me. I do think I have a more significant capacity to be present with other people in their suffering. And I couldn't. When my mom died, I was shut off to the world. I think that this idea of kintsugi, this is a Japanese art of taking broken pottery and putting it back together and creating something beautiful and new from the pieces. And what I like about this art form is that it doesn't try to pretend that the cracks are not there. In fact, they're always highlighted in gold. And I think of that, in terms of my own brokenness. I think that I'm different, but the brokenness is still so much there in me. But hopefully the ability to sit and process and feel that pain is creating something new and different, maybe more beautiful than trying to hide from that pain. So I really think that suffering has to be acknowledged. And we've got opportunity to acknowledge it in medicine and to really see post-traumatic growth in our students if we allow this to happen. But it's unfortunate that disengaged care has really become normalized in medicine. And so many of you have a sense of that. Some researchers there's a really great article. They say many of the practices and assumptions of medicine seek to escape the reality of suffering, usually through denying it, objectifying it, or even sentimentalizing it. And we have a hard time authentically facing suffering in medicine. And this is a great TED Talk if you have the chance to watch this. This is Dominic King, who's now a practicing doctor, talking about his struggle with suicidal ideation in medical school. He said during his first year of medical school, he was experiencing depression. And someone came in to give a talk to his class and talked about how physicians are disproportionately affected by suicide and the rest of the population. You all have heard these statistics before. And this was horrifying to him. And he started to do some research, like a good medical student, on what was going on here. And what he found was the correlation between disconnection and suicidal ideation and the completion of suicide. And this was so worrisome to him because he said, medical school is teaching me how to disconnect. I'm disconnecting from my friends and family so I have enough time to study. I'm learning to disconnect from a human being in order to cut into my donor body in the cadaver lab. And this was troubling to him because if this is disconnection that he's learning, this increases isolation, depression, and suicidality. So what he says is disconnecting yourself is a defense mechanism that we use in medicine to deal with the horrible things that happen to people. And horrible things do happen to people in medicine. And he said things really began to change for him. He noticed the particular moment that it changed for him. He was a second-year medical student in the standardized patient lab, and he was with a patient actor that he had to break bad news. And he had to tell a young woman that she had stage 4 breast cancer. And after he told her that, the patient actor, she said to him, "I hope I never have to get this news. But if I do, I hope it's from someone like you."
Mm.
He said it changed him, that he connected to a fake patient in a transformative way. And he said, "I became connected again by taking care of people instead of diseases. And I do that every single day of my life now." And he says, empathy, which we typically think is a soft skill, is the most important skill any physician can have. It keeps you human, it keeps you connected to other people. I think this is the perfect example of how burnout is not the same as compassion fatigue. Don't get me wrong, compassion fatigue is real. I think of the clinicians taking care of people in ICUs during the COVID pandemic where people are dying alone, and how terrible watching that must have been. And I think compassion fatigue happens in those moments, but it's not the same as burnout. We shouldn't conflate these two things, because it was connecting to people that was the antidote to burnout for Dominic King. In fact, research shows this. Increased compassion, and let's remember that's co-feeling, connection, leads to increased physician well-being, job satisfaction, quality of life, decreased burnout, and the same is true. Decreased compassion for patients, disconnection, protecting yourself, leads to increased burnout. So we need more connection, not less. So what can we do about this? I believe we have to intentionally create opportunities for connection in both medicine and healthcare, and also medical and healthcare education, both of these things. So this might be an unpopular opinion, but I actually have issues with patient-centered care. Now, I understand why patient-centered care is important. The pendulum swung, it needed to go toward patient-centered care. But what I think we should be focusing on, and some of you might remember this in the literature, this was in the 90s, relationship-centered care. I think we need to bring this back, this idea that both clinicians and patients, or trainees and patients, are affected by healthcare. Relationship-centered care says that the practice of medicine is inherently interpersonal, and relationships matter. Not only patient and clinician, but the patient and their family, and clinician to clinician. All of these relationships matter. And it's founded on these principles of personhood mattering. Affect and emotion are important in medicine. We don't say that all the time. Right? And that relationships are good for us. They're morally valuable, and they can actually lead to better health. Rita Sharon, she's actually an MD PhD, but Rita Sharon started the narrative medicine movement. And she says, through authentic engagement with their patients, physicians can cultivate affirmation of human strength, acceptance of human weakness, familiarity with suffering, and a capacity to forgive and be forgiven. I don't think we are telling healthcare or medical student applicants, come do medicine. You're going to learn the capacity to forgive and be forgiven. Right? It sounds wacky. And yet it's so true, especially if you have post-traumatic growth. But what's important here is that this idea troubles the notion of altruism. I understand why altruism exists in medicine, but what it can cover over is the mutual giving and receiving that comes between clinicians and patients, that clinicians get just as much from their patients as patients are getting from them. And it's not about selfless altruism. It's about a mutual exchange of giving and receiving things that are so core to who we are as humans. An example of this, some of you might have Schwartz rounds at your hospitals. We have one that we started at St. Joe's that I think is a good example of connection and vulnerability in action. So this was named after Ken Schwartz. He was a healthcare attorney who was at Mass Gen and was dying of lung cancer at the age of 40. He was worried that healthcare was losing its focus on compassion. He had published an article in the Boston Globe that he said his caregivers were what made the unbearable bearable. Compassion from his caregivers. So his dying wish was to create a center dedicated to compassion in healthcare. And Schwartz Rounds, which I'll tell you about, was piloted at Mass Gen in 1997, and it's now all over the world, 600 sites internationally. So Schwartz Rounds kind of looks like this. We get a panel We have a planning committee that we identify a panel of people to tell their stories. These are staff from all over the hospital. We have had our head of our cafeteria, physicians, residents, PTs, OTs, pharmacists talk about not the medical management of patients, but what it feels like to take care of patients in this current environment. They tell their story. This is an image of Schwartz rounds at UCSF. And then the audience participates and they share their stories of what it's like. So this is about normalizing, humanizing vulnerability and compassion. Some previous topics we've done at our hospital: when everything you have is not enough, carrying through a pandemic. We did that during COVID. The patient I will never forget. The healer as patient, learning firsthand from illness and injury. We had our own physicians talk about what happened when they got so sick, almost died in the ICU, and what being a patient did for them. That's post-traumatic growth, right? When caring doesn't feel good, difficult days, difficult patients. And that last one, you might guess that I had something to do with that title, that theme: stress, burnout, compassion, fatigue, when connection heals. And these have been really powerful for us at our hospital. So are they effective? I mean, research just keeps coming out about how effective it is. 90% of people report better communication with their coworkers. 86% reported feeling more compassionate towards patients and their families, and a feeling of reduced isolation, reduced languishing. And look how effective these are. Schwartz rounds is a really powerful way. But I want to remind people that reflection doesn't have to be formal like it is in Schwartz rounds. We can incorporate reflection like good Jesuit educators, right? At every turn. So what might that look like? Normalizing check-ins after serious events, especially with our trainees. I cannot tell you how many times medical students will come into my office and say, I gave chest compressions for the first time ever. It was my first code, and the person died. And then we moved on to the next patient and no one said anything. And how jarring that is for them. And so sometimes we have to remember to normalize this and talk about it, what that experience is like. And I think brief reflections at faculty meetings or staff meetings, spend the first 5 or 7 minutes just having someone share, like, what's the most meaningful thing that's happened in the past 2 weeks? What's the hardest thing you're going through? This is really easy, low-hanging fruit, a way to start normalizing vulnerability in healthcare. Now, what about our students? How can we help our students foster more deep, authentic connection to cultivate those skills that will allow them to be truly compassionate? Joanna Shapiro is a medical educator. She's been a medical educator for over 30 years. She's also a psychologist. She says, without acknowledging their shared mortality, frailty, and vulnerability, students will not be able to make much sense of truly caring for others. It's hard to care for others when they're suffering, when you're not in tune with your own. But it turns out we are really bad at helping trainees talk about their suffering, patients suffering their own. We're not walking around being like, let's talk about your brokenness. I kind of think we should, but we're not good at it. Right? So this was a piece that came out in the Atlantic. And John Tyler Allen says, while medical schools may include lessons like things like listening skills and fostering trust, tacitly, students are learning to value objectivity, detachment, wariness, and distrust of emotions. That is the opposite of what we want them to do, to be present with the suffering of other people. Sometimes we have professionalism education, but I assure you, professionalism is not the same as compassion, not even close, and not even close to being vulnerability. We are missing the mark when we focus too much on professionalism. I do think we get closer when we talk about professional identity formation. So this is this understanding that medical education, healthcare education, it's a socialization process. Right? It's like the military. You are developing a new identity. So for us, the question has to be, what kind of clinicians, what kind of people do we want our students to become? Professional identity formation says that this is a transformational process from a lay person when they come into school that involves the establishment of core values, moral principles, and self-awareness. Whether we like it or not, all of us in healthcare education, we are in the business of character formation. This is a moral calling. This is a moral education, and we have to talk about that we are changing who students are at their core. So what kind of questions do I think students should be asking in their training? What is it like, really like, to be sick or injured or chronically or terminally ill? The lived experience of illness. What's it like to get a terrible life-changing diagnosis? What would that feel like? What does it mean to suffer physically, emotionally, spiritually, psychically? What is suffering? Let's talk about what suffering is beyond physical pain. What are the social, political, cultural, racial, class conditions that contribute to health and illness? Right? Those are really important. Okay, how do we teach this? Well, it's not going to be through lectures. That's not going to work. This was, if you guys remember the slow food movement around 2015, some of my colleagues in the medical humanities were calling this the slow medical education movement. We need to do this through slow medical education. So it's discussion-based, reflection, and an emphasis on real mentoring and feedback. So relationships, real relationships, where mentors know that they are in the business of character formation. I am biased, my background's in the medical humanities, but I do think it is the medical or the health humanities that are going to get us closer to developing these hard skills of compassion and vulnerability in medicine. So the health humanities, we use the wisdom from all sorts of fields in the humanities. So art and literature and history and religious studies, law, to think through the pressing human problems of medicine and healthcare. So the assumptions here are healthcare is laden with existential questions. At every turn, there's questions about why do people die? Why do children suffer? These are everywhere in medicine. That clinical practice is inherently interpersonal, which we talked about earlier, and that illness and suffering are obviously about more than just the biological body or biological dysfunction. And so we want to foster a richer understanding of the human experience of illness and health and ability and disability, identity, gender, all of those questions that are circling around us. Right? My colleague and friend, Father Jim Clifton, he says, the humanities allow us to imagine ourselves into another world. And this is what struck me. When we can do this, there is never a patient who doesn't belong. When we can imagine what it might be like to be suffering with addiction, when we can truly imagine what that's like, there is never a patient who doesn't belong. Everybody deserves our care and is part of the healing relationship. Now, this just came out at the end of January this year. Okay, so Holly Humphrey, she's a critical care doctor. She's the former dean of med ed at the University of Chicago, and she's the current president of the Macy Foundation. And she wrote this opinion piece that said, defunding liberal arts is dangerous for healthcare. Some of us have been talking about this for a long time. But what she says is medical educators are looking to the humanities to help students transform medical knowledge into clinical wisdom that will enable them as physicians to optimize the health of patients and entire communities in our increasingly diverse and complex world. Okay, I might use more flowery language than Holly Humphrey, but this is exactly right. And in some ways, what she's saying is our medical students are students of humanity, and they're getting there by way of medicine. So let's equip them to be students and practitioners of humanity. There are some things I've learned along the way. We incorporated the medical humanities as required curriculum at Creighton, and I'll share with you briefly what our curriculum has looked like. And I can tell you what we learned along the way. So incorporating the humanities, what doesn't work? Didactic lectures. You're not going to teach someone they're not going to have a transformational educational experience through 75 PowerPoint slides. Offering only like optional or extracurricular or elective courses, that communicates to them that it doesn't matter. Not offering meaningful grades. Okay, not a fan of grades. But if everything else in the curriculum is being graded, but the medical humanities is like pass fail or just show up, we're also communicating something to them about how important they are. Not integrating it into the curriculum. I'm someone who thinks the humanities should be invisible. That if you're giving a lecture on pulmonary dysfunction, whatever, the lived experience of having whatever disease you're teaching should be embedded in that. right? It should be almost invisible. And that it should just be, this is the way you learn how to be a clinician. You care about these things. We have to integrate it into the curriculum, and we can't make it seem like extra work. This is hard when they've got board exams that they're like, I want what's relevant on the board exam, and the humanities is not. I do understand that this is an uphill battle. So our humanities and ethics curriculum, it is required throughout all 4 years. I will tell you about the first 2 years. We have 14 sessions in the first year of either ethics or humanities, and 10 in the second year that all 120, 130 students, depending on the campus, have to attend, and they're in small group format. And here are some of the topics. So in year 1, we have an intro to medical humanities. We talk about implicit bias, how doctors think, the shortcomings of science, narratives of medicine, the nature of suffering. We talk about the US healthcare system. How does it work and for whom is it working? Turns out not working for many, right? The social determinants of health. We talk about trauma, and then death and dying. And in the second year, we have reflections on med ed. Who am I becoming? We have our students go back and read their essay that their personal statement to get into medical school, and say, do I even recognize that person anymore? What's happening to me? The patient-physician relationship, history of medicine, about historical racism haunting contemporary practice, spirituality and meaning making, and the medical humanities. We talk about practical applications for third year. How did the humanities affect your real life encounters with patients? We also have these amazing student interest selectives. In Arizona, we've got 28 of these kind of medical humanities student interest selectives. All students have to take at least one, but they can take up to 3 before they progress to the third year. And they're all focused on the social, moral, interpersonal, experiential elements of medicine. So in Arizona, we are a healthcare campus. Like, we have OT, PT, pharm, nursing, 4-year medical school, but we don't have an undergraduate campus. So I went and partnered with Arizona State University to all of their humanities departments. And I was like, who's interested in teaching medical students? And it's been such an amazing partnership. They get to come over here for their 5-week course where they've got the divided attention of students, no more than 12 students per class. So it's kind of a seminar style, dialogical kind of course. And they developed courses like music, grieving, and the end of life, the power of art, drawing, observation, and empathy, religion and bioethics, the health effects of nature and art exposure, healing traditions of Latino America, like really, really cool courses that we developed. These are some of my students. This was about 3 years ago. They took Drumming Cultures of the World. What can percussion teach us about community building, collaboration, health, and humanism? This was from one of our professors over at Arizona State. And they performed on an impromptu performance on our back terrace, and all 100 of their medical students just decided to show up, their classmates, and it was incredible. It was really, really neat to, this is how we see students as whole people, right? This is a course in Omaha, on the Omaha campus. My colleague, Rachel Mindrup, she's an incredible portrait artist, and this was her group of medical students. And what they were doing here is she asked them to look down and draw their lap. What do they see when they look into their lap, their hands, the way their legs are crossed? They didn't know why they were drawing this, but they drew this. And when they were finished, Rachel, who has a son with a chronic illness, she said, the perspective you just drew is a parent in the waiting room when they're waiting for their kid to get out of surgery. All they can see, their world becomes looking down at their lap. And this is how we change our students. This is how we transform them. It's these kinds of experiences. If you're interested, we published not too long ago kind of the outcomes of our curriculum. You can see that here. Hopefully my colleague, Gail Jensen, she's a physical therapist, one of the co-authors, she said she'd be here today. So shout out to you, Gail, if you're here. This was a fun kind of project to just look at, were we having an effect on students and their professional identity formation? In their words, our students, we did qualitative interviews, and these are some of the things they said. Personal reflection and conversation with other students have led me to believe that humility, empathy, and the ability to listen are the 3 most important characteristics physicians can have, right? This is not, I don't know, understanding the Krebs cycle or whatever. This was like the most important, our empathy. And then this student said, we must take time to reflect on our experience, to listen to others, recognize humanity behind every diagnosis, They said, we dived deep into how medicine is so much more than applied science. We've discussed how serious illness chips away at more than the biological body. And then this student said, science cannot always compensate for realities like pandemics and opioid abuse and struggling mental health. The practice of medicine sometimes means making seemingly impossible choices without a structured treatment plan or rule book or diagnostic criteria to fall back on. Now, these were first and second year medical students. You know, they learn really quickly that medicine is not an algorithm once they're seeing patients. But I think we helped them to see this earlier, that medicine requires your whole self and it's not black and white. So just reminding you of that quote that I love so much, of what I think we're hopefully doing with our curriculum, getting our students to be able to recognize the gritty reality of medicine, of our world, and be present and respond to it. And if I may, I just want to share one quick little story, and then I would love to answer your questions and have a conversation with you. So last night I was teaching a faculty development session, and one of our surgeons was there. She's a burn surgeon in our county hospital's burn center. And she said they had a young patient in his early 40s, and he had been in their burn unit for 42 days, and he had still on the ventilator, and they couldn't get him off, but they couldn't figure out why. And she said, 2 days ago, the resident on the team said, God, I heard he has 2 young kids. If I was in the hospital for 42 days, like, I would want to see my kids. And so they can't have children on the burn floor, but he arranged to where he could bring them to look through a glass window that was in the patient's room. And less than 48 hours after that, the patient was off the ventilator. And what the surgeon said to me was, yeah, you know, it was like his ability to empathize with this patient, to make this decision and get him off the ventilator faster than any kind of medication I could have given him. We were stumped. And this is why I think empathy, compassion is a hard skill in medicine. The clinical intervention here was empathy. That's what got this guy off a ventilator. And I was so grateful she told me that story last night, because I think it really captures what we're talking about here today. So with that, I would love to answer any questions that might be coming in through the Q&A feature. And thank you so much for giving me your time and attention.
Nicole, if you'd stop sharing your slides so we can continue our conversation, that would be wonderful.
Absolutely.
I wish we all had an applause function, because I really think that you deserve it. My mind is going in so many directions, and I don't want to let other people ask questions since I just want to talk. But I won't do that. I'll behave. We have one question that's come in, and let me say, the person really complimented you on your presentation, and noting that your focus has been on the individual and interpersonal levels. But then notices that our clinical learning environment is at the institutional and burden causing systemic policies are not changed, the suffering will continue. And this is an easy question. What's your solution to the bigger problem?
Yeah, how do I fix the problem of healthcare? No, I so appreciate the question, because so much of languishing burnout and moral injury is caused by our inhumane healthcare system. There's no doubt about that. I do think that this is going to require clinicians to say no more, to really take a hard stance that this is painful to patients and their families, yes, but to clinicians, that this is intolerable, that we can't do this anymore. So I think it is beneficial for all of us. If we're ever invited to talk about burnout or whatever, compassion fatigue, moral injury, we have to speak to the system problems that are causing this. Some of the research coming out says it's burnout is like 20% controllable by the individual and 80% systems. And we have to keep repeating this over and over and over again.
A question that has some similarity comes from our Joel Reynolds, who's a professor in the philosophy department, specialized in a lot of great stuff. I particularly like his work related to disabilities, but he's thanking you for your fantastic talk. What he says is that some of the issues resulting from systemic problems can't be directly addressed by a single clinician, like time resource allocations, inaccessible equipment because of medical decisions, administrative decisions, or issues fully outside the clinic, things like food deserts and stuff like that. Can you talk about the suffering that can arise from a feeling of a lack of control and how recognizing that might be distinct from recognizing the direct suffering of the patient in front of oneself?
Yes. So, hi, Joel. I know Joel. um, it's great to hear your voice through Miles. Yeah, lack of control. So that's it, right? That's the moral injury. That is absolutely the moral injury. And I think we have to hold people accountable. So, Joel, you were alluding to hospital administrators' decision making. That ultimately down the line, and we saw this saturated in the pandemic. There's no doubt about that. I think as medical educators, as healthcare educators, we have to teach our students this. So the critique coming from some is that this is woke medical education and that there's something wrong with this, that we're making our students too woke, which is derogatory, right? We have to keep doing that. We have to really be committed to our students understanding that a life in medicine means understanding the socio-political race class issues that lead to ill health down the line. And I think we need to do a better job pre-med, pre-health. If you want to go into healthcare or medicine, you better care about social issues. And if we can get clearer on that, that you're not enrolling to be an applied scientist who's just going to fix and cure, we've done a bad job at the start of helping frame what healthcare, a life in healthcare really means.
That's interesting. And I mean, I often think about, the AAMC has done a number of wonderful things. And I think there's been a real change in recent years about looking at these social issues. But I can just remember dealing with this overwhelming thing that we're trying to make physician scientists. And the
Yes.
people who were not physician scientists, you were sort of, oh, well, and that was problematic. I think that, the idea that we could make physician humanists, and some of them will be scientists, that's perfectly wonderful. No problems with MD PhDs. The issue though is to really get this. And a question here, interesting, from Eshere Chaudhuri. I probably didn't pronounce the name wrong, and I apologize. Right, but to what extent of variation do you think in ethical values are recognized in a primarily Western medical system and possibly integrated in medical education? So I guess there are a couple things that I'm unpacking from that question. One is different ethical values that could come out perhaps of differing traditions from where the students come, but also that if you look at a group of students who are Americans, whatever that means, kids who have grown up and been socialized in the United States, really having different ways in which they take a look at the problems in front of you. What do you think about ways that perhaps what you're talking about, the humanities and integrating into medical education, could look at that?
Yeah, this is such a wonderful question. And I have so many thoughts swirling around in my head. Uh, so it would mean taking diversity seriously, and it would mean learning from other cultures. Uh, so on a podcast recently, I had heard that rates of burnout among PCPs was equivalent among American PCPs and European PCPs,
Hmm.
which throws a wrench into the idea that it's our broken American healthcare system that's causing this. We're saying they're both burnt out. But I
Hmm.
think it's because it's a particularly Western problem that we have here, which is individualism, and this failure to really recognize community connection. Now, this is just my little kind of like armchair philosophy assessment of this, but I think we've got a Western problem here. So much richness and beauty can come from incorporating Eastern thought, but we're how do we take it, we need to take it seriously in the way we're training our doctors, and we like have nods to it every once in a while, but we have so much to learn about what it means to be with other humans in this world in a way that even transcends the problems of our healthcare system.
Mhm. Yeah, that's a great start to what's a whole other discussion. My colleague Chris Spivak, who is a physician who actually is covering for me on the consult service today, so I could do this. Thank you, Chris.
Thank you, Chris.
Chris asked the question about, you know, the challenge in recruiting physician mentor coaches who can spend times with the students who do this. Part of it is that they just can't because of their clinical practice. Any thoughts about overcoming that challenge? Any secret ways you have to make the administration at
Yeah.
Creighton and in Arizona just say, "Oh, okay, we'll give you time off"?
I know this is the challenge, right? And then we get the same people over and over again who are doing it out of the goodness of their heart, and we're just taking and taking and taking from them. So it is another kind of area that I think we need to take seriously. So we need to have resources that are dedicated to this, even if we can't protect time, but we do reimburse in some kind of fashion to communicate value. It's the same thing that happens when we like don't grade the humanities or don't make it required. We're communicating something about value. We need to communicate value that we believe mentorship and coaching is so important that we're willing to put resources towards it. Um, and gosh, I don't know, do we show return on investment of students who get good coaching and those who don't? But we have to. It is imperative for the kind of character formation of our students.
You know, one of the things that I was thinking about is how I was formed as a Jesuit after I did my medical training. So I entered the society after I finished residency. But one of the things is that formation continues with the real development of role models and the people who we call our superiors. And I'm wondering about, if we do all these things, do we get some students all dressed up with nowhere to go, so to speak? In other words, we develop them in ways that does make them vulnerable, open, and then we send them to Lord of the Flies daycare, you know, where um, I think it's important we do this with our students. I also think that it's important about ways in which we can try and do more and more of this with our faculty. And I wonder if, I
Yeah.
bet you thought of that yourself and
Yeah.
what you've been doing with that.
You know, I don't want to exaggerate to say it's what keeps me up at night, but I've given a lot of thought to it. So I do think that there have been times where I have worried that we've set them up, you know, like it's a rigged game. We set them up. We said go be vulnerable and compassionate, and then the minute it's either third year or they're an intern, it's out the door. No, we don't do any of that idealized nonsense they were talking about at Creighton or whatever. So we need it in GME, graduate medical education, with our residents. Absolutely, we need to do this, and we need to do it with our faculty. There's no doubt about it that they're continuing to form as people. And if it stops at the end of medical school, we are doing a terrible disservice.
Mhm. Can you comment, my good friend Lachlan Farrow from, we worked at the Beth Israel in Boston together, and he's at Harvard. And he asked, can you comment more on viewing character development as the central task in medical education?
Okay, so right. Maybe it's not the central task. We have to have them meet some competencies to be able to go and take care of people. But we all know that we could have the smartest clinician on the planet, and if they can't see us and understand us and feel for us, there are actually poorer outcomes that happen. I am more inclined to follow my clinician's treatment plan if I trust that they care about me in some capacity. Um, and I guess I'm brash in my statement that we are in the business of character formation, but I think if we're not, we have set people up for pain, because medicine, whether we like it or not, is full of the human condition and suffering and loss. And if we don't equip them for that, we are hurting them.
Thank you. Thanks very much. Jim Giordano, one of my colleagues here at the Pellegrino Center, he notes that there's been what he thinks more attention in European medical education to some of the things that you've been emphasizing. And as he says, if you were Lord of all that is, even for a short time, how would you, in practicality, fix the US system of medical education?
Oh my gosh, this question. Okay.
You got about 2 minutes.
Right. If I could, okay. I think that I would be rethinking admissions, um, really rethinking, and I would be rethinking pre-health and pre-med education. So we got to start a little earlier to get the right people. They would have real meaningful clinical experiences basically day one. And we would have clinicians telling them over and over again, yes, you need to know this basic science stuff to minimally pass these ridiculous board exams, and really giving them the message that that is not the most important thing. I think I would make it pass fail so that there is less competition and less focus on exams and grades, and a real focus on getting to know students and saying, are you ready for what it takes? Which will mean rethinking assessment and what it means to think like a doctor and be a doctor. And there would be very few, if any, multiple choice exams. That's what I'm saying.
This has just been great. And oh, good. I got a little note. We got a little bit more. One of the things I wonder about is what do you do with the medical student who says that this is all bovine excrement? How do you deal with resistance?
Yeah.
I mean, part of it, and I also think, is that when you're young, this is a lot to throw on somebody,
I know.
particularly when they might be resisting. Maybe what the resistance is they're realizing, uh-oh, this is getting me into an area of emotions that I haven't expressed or thought about. But I wonder how you deal with that. I don't mean disciplinary wise, but I mean just in terms of making disciples as opposed to people who are just there picking their nose.
I love the colorful way that you have framed this. So yeah,
I
resistance.
teach medical students.
So resistance is a real thing. It really is. I think we get less of it at Creighton. We're very clear that we say to them, if you're not interested in this kind of way of learning and thinking in the medical humanities, you're going to be disappointed. So you should probably go somewhere else. We do say that to them. But that's not to say there's not resistance. There's a resistance all the time. I think I have to do my own internal work. And my own internal work is A, I can't rescue people. That's also not what I'm supposed to be doing. And B, that I'm planting seeds that they might not yet be ready for this. And they can't hear it and they can't let themselves feel it. But that their medical training inevitably will confront them with these things. And they will at some point have to face it. And hopefully I've planted seeds or developed relationships where now they know who to turn to when it is time to talk about this.
This is a question from an anonymous viewer who says, the clinic we founded is geared for uninsured Hispanics. And have you integrated into curriculum how it feels to be a patient or family member, a patient who cannot speak the language and doesn't understand the medical system at all? For instance, our patients often call the clinic after referral because despite having an interpreter, they didn't understand what the specialist told them. Interpreters themselves are reporting having patients call them with questions because they didn't understand what was going on during the patient-doctor exchange. So I think the question is, what does it mean, even if you have skilled interpretation and you come from a different language tradition and a different culture? Any ways in which you've been able to work on that?
Yeah, we have. So we're in Phoenix. So we've got lots of folks who speak Spanish in our community. And we have a free clinic that is basically Creighton's. It's called St. Vincent de Paul. It's incredible. And all of our first and second years required clinical experience is in this clinic with hour-long appointments with a physician and almost 100% Spanish-speaking clinic. And getting to see how that clinic runs. And over again, people are saying, these people are getting way better care than I get with my insurance.
Mm,
It has been such a beautiful opportunity. And we talk about, is it fair to learn off of vulnerable people? I'm an M1, I know nothing. Is this fair? We have those critical conversations alongside the wonderful kind of immersive experience that they're having.
mm. A question that comes from a listener in the United Kingdom right now. And so it's 10 o'clock at night, so they really wanted to listen. I'm wondering about, and the person asks, do you think that the pandemic, in a way, almost created, first exposed our vulnerability as medics with a certain inability to cope with patient suffering? In other words, did it show we can't deal with it?
Mm, yeah. Yeah, everything got turned up in the COVID pandemic. I think it was all of our same problems on incredible volume and incredibly saturated and painful. And I think we have the same problems even at the height of the pandemic being over. Was an exaggerated, obvious thing. And yet, I don't see much being done about it. And if a pandemic is not going to get us to listen, I'm worried.
Yeah.
I'm really worried.
Yeah, questions come through that's similar to questions that I often get. I really enjoyed what you said, but that, to be humane, to listen to patients, to interact with them is often hard due to time constraints.
Yeah.
And so, how much pressure from administration on productivity? There's so much that it really gets in the way of trying to have this relationship-centered care that you talked about. How do you blend the two opposite views?
Yeah. So it's hard because I'm someone who wants to blow up the system, and I don't want to say it's okay. You can connect in 15 minutes or less or fewer. And the thing is, you actually can. That doesn't mean we need to keep the system the way that it is. But I've given a presentation with a colleague, two colleagues. They're emergency medicine physicians, and they talk about how they've had to step into vulnerability and into compassion and connection so quickly,
Mm,
and they are able to do it. I don't want that to help us like maintain the status quo that nothing needs to change, but I do think that even if we wish it were different, we still are able to do this quickly.
yeah, boy, that's great. Um, do you think that this is an interesting question from a gentleman, Frank Thomas. Do you think there's a relationship between burnout and the concept of acedia, ACEDIA, for those who are?
Can you tell me what acedia is?
Yeah, acedia is a thing that often was considered as sort of the sin of monks. In other words, it's sort of a loss of pleasure and growth, the
Oh,
loss of an inability. It has a lot, it's the spiritual equivalent of languishing.
yeah. And is there a connection there? The question was, is there a connection between that and burnout?
Yeah.
Yes, yes. And I think it is the central problem. I think we are languishing um, because either we are burnt out, where we start to use all of these terms interchangeably. But what is happening? We are turning inward. We are shrinking ourselves. We are protecting ourselves because it's too much.
Yep.
Instead of extending outward and connecting to others, which is the only way we're going to make it through the pain.
No, I've often said that I think you can tell a doctor by what she or he listens to in the car on the way back from the hospital, and I'd rather have them play Tina Turner, "What's Love Got to Do with It," than Carly Simon, "And I Haven't Got Time for the Pain," you know? Um,
That's it.
yeah, that's really it. I wanna thank you. I really would like to keep this going on for about another hour, but, I can't do that. And we also are excited to hear what Francisca Finkel is gonna present with her presentation. Um, I can't thank you enough, and I got a couple ideas to talk to you about later.
Okay. And
So, so just thanks for all the things you did, for the ways you opened your self up, for the way you shared a little bit about your own personal story. I appreciate all that. And I think that, you'd be getting an overwhelming realm of round of applause right now, if folks were able to do that. So thank you so much. And so you and I can go backstage, and I'm now going to introduce Claudia Sotomayor, Dr. Claudia Sotomayor, who runs our ethics consultation service and is a member of the Pellegrino Center for Clinical Bioethics, to introduce Franziska Finkel. So you guys take it away. Bye-bye.
Thank you, Miles. Thank you so much. And Nicole, thank you so much for this thought-provoking talk. The fact that you portrayed this concept of interdependence and how this interdependence, human interdependence, highlights our vulnerability and connects. It's bravo. It's wonderful. Thank you so much for doing that. So Miles gave me the wonderful task. I'm very honored to do this, to introduce our student, Franziska Finkel. I don't know if you all are aware with this, but in 2019, we created this program, the Pellegrino Student Scholars. And this program had the aim of creating this interprofessional space where medical students and nursing students can learn more and understand more about Pellegrino's work. So Franziska was in our program in 2019. She'll be graduating from the School of Medicine and will begin her residency in general surgery in Harvard, UCLA. We're very, very proud of her. During her time here as a Pellegrino Student Scholar, she was very interested in learning more about issues around moral distress in medical students and how can medical students navigate through these problems. And she did a great job. She created a flowchart where the medical student now can go and take a look. If I'm feeling moral distress, these are the steps I need to take. And these are the tools and the resources available for me to be able to deal with this moral distress. After her program, she never left. She never left me. Thank you for that, Franziska. No, her passion and her interest in social justice and health justice, it was very evident. And we stumbled upon a problem here not a problem, but a situation. We started seeing an increase of ethics consultations related to unrepresented patients in the ICU. People needed, the clinicians needed to make decisions. People were not represented. So we had this conversation over and over amongst clinicians, and that sparked a lot of interest in Franziska creating this the project that she's going to present to you in a minute. But not only that, she also worked in different projects. She completed a concentration in health justice, which included the opportunity to meet with local lawmakers to discuss maternal health disparities and to present her ethics work at the Georgetown School of Law. She also won the essay contest of the Academy of Medicine with the essay In the Space Between Patient and Cadaver, Disease, Donor, Patienthood, and the Risk of Moral Distress in Transplant Surgeons. Her interest in ethics includes moral distress, surgical ethics, and transplant ethics. Without further ado, Franziska, take it away.
Thank you so much for the great introduction, and thank you so much for holding my hand through all of this over the last few years. It's been a pleasure to engage in this work with you all. My slides should be up. Thumbs up if you can see them okay. Perfect. Thank you so much, Claudia. Okay, so as she was saying, my name is Franziska Finkel, and I'm going to be talking a bit about a project that we did together looking at unrepresented incapacitated patients in the Georgetown intensive care units. And this was a single center quality improvement study that we also did with Dr. Christopher Spivak, who I believe is also on this call today. I have no conflicts of interest to discuss. So over a period of 2 months, we had about 5 consultations come into the ethics consult service regarding patients who were unrepresented and had no capacity to make medical decisions. People were expressing a great degree of frustration with the process and a great degree of moral distress as well, feeling that they couldn't do what they needed to do for these patients because of issues obtaining consent. So considering the sheer number that we had gotten in a short period of time, we wanted to sit down and look a little bit about how our internal processes address patient care scenarios like this, and how in a broader national sense and in a local level, what the laws look like regarding consent for these individuals. So just to provide some definitions to begin, an unrepresented patient is one who lacks friends, family, or acquaintances to act as a surrogate decision maker. It's unclear how many of these individuals exactly are unrepresented in our health system. There was an estimate that about 16% of ICU admissions and 5.5% of ICU deaths were in individuals who were unrepresented. And it's also estimated that 3 to 4% of nursing home patients lack representation as well. Sometimes this population is also referred to as the unbefriended elderly. So there are some other terms that are thrown around in this case. But we do know is based on the amount of elderly individuals who are unrepresented, this is a population that's likely to expand considering our national demographics. Oftentimes, these are members of marginalized or vulnerable populations or represent an intersection of several kinds of marginalized individuals. Oftentimes, these patients can be unhoused, suffer from substance use disorder, or live in extreme social isolation, especially elderly patients who do not have any living friends or family. And this can also be people who have immigrated to another country and lack any local contacts who are able to speak to their preferences, wishes, or best interests. So we took a look at the laws, looking at different regions, and we were interested to find that there really was no consensus in terms of what was the best course of practice for these individuals. So of course, in an emergency situation and per DC Code of Law, they state that consent is not required as it is assumed to be given under those circumstances. So it's the concept of implied consent. Outside of an emergency situation, there are different rules that govern consent. And in the United States, 37 states do not have an out-of-court process that's going to deal with the appointment of a guardian. So it will, in a majority of the cases, have to go to a judge. Within the states that do have these out-of-court processes, there are widely varying laws, ranging from formation of boards with different groups of people, including medical ethicists and patient advocacy, and some that leave it up to the treating attending alone to make the major medical decisions. And of course, this brings up questions about determining the right action for the patient. And it's considered problematic in times to have the treating physician make these decisions. And so I found it interesting that there was such a great degree of diversity with these laws. So this brought us into the moral distress that the individuals who were initiating the ethics consults felt. And this sort of ties into what we were discussing at the last lecture, that great talk that we just listened to. So moral distress is the sequelae of being able to follow one's deeply held moral beliefs. These are also known as morally injurious acts when a situation occurs in which someone is not able to follow what they feel is the best course of action. And this has historically been studied and is a concept that originated with soldiers who experienced traumatic instances during war in which they were not able to do what they felt was right, but has now increasingly been explored in the healthcare sphere. This typically has been focused on in nursing research, but increasingly so has become the target of has been a focus for physician research, especially in light of the COVID pandemic, where there was so much emphasis on feeling unable to do what was right by the patients in many respects as a result of scarcity and risk and things like that. This is also a factor that's known to contribute to burnout in individuals. It can also exacerbate or initiate symptoms of mental health conditions like depression, PTSD, and anxiety. So we can see that this adds to the already difficult sphere in which we have to navigate making these decisions for these individuals. So I did want to tie it back to some of the work of Dr. Pellegrino and our ethics roots here. So I think that when we look at the vulnerability of this population, it really calls us to heavily scrutinize our own practices. So in the course of doing the background research for this presentation and this project, I found a really interesting article that highlighted improvement of care and scrutiny of the care for highly vulnerable patients, such as those who are unrepresented, as a moral imperative and a way that we can enact a principle of health justice. And so I think when we look at vulnerability much more broadly, it's this intrinsic aspect of the physician-patient relationship. And there are some aspects of that that cannot be mitigated. They are in poor health and they are coming to the physician hoping that our character and our ability to navigate the system and to make good clinical decisions will heal them. But there are other layers of vulnerability as well. And so then a question emerges as well, what layers of vulnerability ought we to mitigate in our search to care for these patients and in our desire to enact the bioethical principle of health justice? So I have here this quote from Dr. Pellegrino that I will read to you all. regarding health justice. So justice, therefore, expresses a special concern for those in pain, the poor, the troubled, the oppressed, and the outcast. Justice transformed by communal concern is expressed in concrete acts of beneficence towards specific persons. So I think that by really focusing in on vulnerable individuals and seeking to improve our practice, especially when there's no friends or family who are going to advocate for these individuals, this was our attempt to contribute to enacting justice for our patients and helping our colleagues as well with their moral distress. So very briefly to go through what we did, we initially designed a focus group of Georgetown ICU staff, including individuals such as nurses, physicians, patient advocacy, and legal counsel. And then following the focus group, we sent out a survey to the ICU through the nursing management and other ICU members in order to get that disseminated. And then data analysis was performed. The focus group, there was a thematic analysis done. And then I used Excel and Stata to analyze the data for the survey. And then a Fisher exact test was a specific statistical test in use. So to talk a little bit about the results that we found from the focus group, initially, we weren't exactly sure where barriers to care for these patients came from. We had heard a lot from physicians about feeling that they couldn't do what they needed to do, particularly when it came to more invasive treatment. And we were curious to find out what was causing delays and what was getting in the way. Very quickly, it came out that legal processes were the major obstacle. So our question was answered there. And then other themes included feeling frustrated with the process of having to designate a surrogate. And then a strong desire for further education was expressed throughout the group and by all members of the group. And also the significant theme that there was not really a one-size-fits-all solution for this group of people, but that they wanted to better understand how they could engage in caring for these patients. So I have here the survey data on the right. Just very briefly, we wanted to find out people's role, the number of years that they've worked at MedStar Georgetown University Health Center, the patients per year who were unrepresented and incapacitated that they had, their familiarity with our process for establishment of guardianship and how to initiate that, familiarity with DC, Maryland, and Virginia legislation, and feeling that a flowchart would be useful in their navigation of care for these patients. We also wanted to assess their opinion on care received, whether they felt care for these individuals was standard, undertreated, overtreated, or situation dependent, and then also the degree of moral distress that these caregivers were feeling. So to touch briefly on some of the results that we found interesting. So overall results for individuals regarding the process within MedStar Georgetown University Health Center, only 50% of people of all levels were familiar with the initiation of the process. And this is again of ICU staff. Only 32% were familiar with the local legislation, and 84% felt that a flowchart would be useful in their initiation of this process. We also have here the overall degrees of moral distress mapped out. What was interesting is that nobody felt that they experienced no moral distress. Nobody felt extreme degrees of moral distress. Rather, we do see a very normal distribution of mild, moderate, and severe that did play out in our survey. And then here I looked for a relationship between different demographic factors and people's familiarity with different aspects of both the process and their opinion on care as well as moral distress. I don't have it on this slide, but initially, there was also an association that I looked for between opinion on care and moral distress, and that was statistically significant, which sort of validated our study results initially and sort of our understanding of moral distress being based on opinion of care and feeling that they could do right by their patients. So the only demographic factor that correlated was years at MedStar, correlated significantly to familiarity with our internal processes, which I think is intuitive. And then surprisingly, aside from that, we didn't really see any other statistically significant associations. We did see that the years at MedStar very nearly was significant in association with opinion on care, and that we think likely was related to degree of experience when it came to clinical care. So just what we learned from undergoing this process is that staff were very unfamiliar with policies and legal procedures, both internally and throughout the region, and that there was a very strong desire for educational materials and an internal flowchart to help them initiate this process. We also found that people were very excited to discuss solutions for educational materials and were really collaborative in initiating that. So it was nice for us to see. And we were also surprised to find that there was no relationship between staff role and the level of moral distress. This is something that we've seen in the nursing literature, where individuals who have a lesser degree of decision-making authority are more susceptible to experiencing moral distress. And this is likely as a result of inability for their moral objective to be fulfilled. And so that was something that I had expected to see, but was surprised that that did not play out in any of the analyses. And then I have also the flowchart that we designed after several iterations with legal counsel and with social work. I'm just showing this briefly to give a sense of how we try to highlight the way that the process works for individuals and then help them initiate that process should it be necessary. So in conclusion, the legal guardianship process poses significant delays in patient care in the DC, Maryland, and Virginia area that can be up to 16 weeks. Staff are morally distressed by these patients and would like more education. And the next steps include assessment of an educational intervention. For example, the flowchart that we designed and other educational materials that we designed as part of this project. I think in the future, we'd be interested to see if we can mitigate staff moral distress by disseminating these materials and making them more aware of how this process works so that they can hopefully get the process initiated more quickly. And here are some of the papers that I referenced for this PowerPoint, and a full version of this paper will be out in the Journal of Hospital Ethics in the next issue. Thank you.